Hello, my name is Brooke Dudley and I'm a graduate nursing student at West Texas A&M. Today we're performing a head-to-toe assessment on my 40-year-old patient who's here for a physical. He has no present chief complaint at this time, but we have done an intake to include his past medical history as well as his surgical history, familial history, social history, his review of systems, medications, allergies, and a full set of vital signs to include blood pressure, heart rate, respiratory rate, oxygen saturation, and temperature. We've obtained height and weight, and we have tested visual acuity and the optic cranial nerve with the Snellen eye chart, reflecting at 20/40 in the right eye and 20/20 in the left eye uncorrected. We're going to start at the head. We're going to start with a visual inspection, looking at our hair texture and length. Were we to have any hair, we would also document the hair disbursement pattern. We are going to palpate the cranial vault, looking for any anomalies, making sure that we are normocephalic and atraumatic. We are going to palpate at the frontal sinuses and the maxillary sinuses, looking for any tenderness, or anything of that nature. We're also going to palpate at the temporomandibular joint. Can you open your mouth for me? Okay, up and down and side to side. Feeling for any pops or clicks, which we do not feel. We're going to test for the trigeminal nerve. Tell me if this is dull or sharp.
Dull, sharp, sharp, dull.
Okay, so our trigeminal nerve is intact. We're moving on to our eyes. We're visually inspecting first, looking at the sclera and the conjunctiva, looking for pink, moist conjunctiva, looking for the sclera to be white, and looking at the lenses and irises for opacity and any drainage or discharge from the eyes. We are going to look at pupillary response, testing direct, consensual, direct, consensual. We're also going to test for accommodation. So if you could look at the wall behind me, pen light and my wall, pen light and my wall. There's a test for convergence. So watch this as it moves towards you. We're also going to test cranial nerves 3, 4, and 6 as we look at the 6 fields of gaze. So if you'll watch this with your eyes only. Looking for any nystagmus or any changes in the extraocular movements. We are going to visualize the optic disc, my hand on your forehead, and we are looking for any papilledema or any indications of changes in vasculature or retinopathy. Thank you. We are going to move over to the ears. So we're going to visualize the ears first, looking for any external signs of any nevi or discoloration, cracking or peeling that may be of concern. We're going to palpate the auricle, the tragus, the mastoid of the ears, looking for any tenderness with palpation. We're going to visualize pulling the pinna up and back, looking at the ear canal and visualizing the tympanic membrane. We do have quite a bit of cerumen, but we do have a good cone of light at 7 o'clock. Pulling the pinna up and back. Again, visualizing the ear canal and the pearly gray tympanic membrane with a good cone of light and good light refraction at 5 o'clock. We're going to test the auditory nerves, the whisper test. We're going to occlude one side. And if you could repeat what I say.
2, 4.
7, 7.
7, 7.
Okay. We're going to do a Weber test. We're going to test for lateralization. So we're testing to see that you hear/feel on both sides of the head. Okay. And then the Rhine test, looking at air conduction versus bone conduction. You're going to tell me when you stop feeling and stop hearing.
Okay. Okay.
That one would have been short.
Okay. Okay.
We are going to move on to our nose. We're going to visualize again that our nose is midline. We're looking inside of the nasal passages, each nair looking to see that the septum is midline, that our nasal mucosa is pink and moist without erythema or exudate, nodules, or anything that would impair our nasal function. We're going to test for nasal patency. Breathe in. Thank you. Breathe in. Perfect. And for our olfactory nerve, close your eyes, please, and tell me what you smell.
Alcohol.
Alcohol, thank you. We're going to move on to our mouth. If you don't mind opening your mouth for me. While open wide, we're looking for oral mucosa. We're looking for pink and moist mucosa. Stick out your tongue, please. Okay, and say ah. We're looking for the uvula to be midline, as representative of the vagus nerve. We're also looking at dentition and any dental caries that may be of concern. We are looking for movement of the tongue. Open your mouth, please. Testing the gag reflex. Intact gag reflex is indicative of that intact glossopharyngeal nerve. You can stick your tongue straight out. Hypoglossal nerve is intact, tongue is midline. And if you could smile and puff your cheeks out. Intact facial nerves. The last thing we're going to look at is our spinal accessory nerve. Can you shrug your shoulders up and down for me? Perfect. Thank you so much. We're going to move on to the neck. So we're going to visualize the neck, and we're going to look to see that our trachea is midline and we don't have any JVD that would be indicative of any cardiopulmonary processes. We're going to inspect the thyroid from behind with hands on either side of the neck. Chin up, please. And have him swallow. Thank you. Feeling for the thyroid on both sides, noting any nodules, noting symmetry, noting the texture, as well as any goiters or any anomalies that we may find. We're going to palpate lymph nodes. So we're going to palpate preauricle, postauricle, submandibular, submental, cervical, postcervical, supraclavicular, and axillary. Palpating for any palpable masses, and if we do have masses, we're looking for tenderness, we're looking for mobility, size, shape of those masses, and noting that as we go along. We are going to move to the posterior thorax. If you don't mind turning for me, or just turn all the way around. Okay, we're going to first inspect the posterior thorax. We're looking for any accessory muscle use. We're looking for chest excursion. We're looking for equal and symmetrical chest rise and fall. I'm going to put my hands on either side of the spine and ask him to take a big deep breath in, watching for my thumbs to rise and my hands to flay out equally. We're going to palpate for any tactile fremitus. So if you don't mind saying 99.
99. 99. 99.
Thank you. While we're here, we're going to go ahead and palpate for any CVA tenderness. Any tenderness over those areas there. Okay, we are going to percuss over all of our fields. Listening for resonance. and noting any areas of dullness that may indicate any fluid or any areas of hyperresonance that would indicate any pneumothorax or any hyperinflation as associated with respiratory pathologies. We're going to auscultate. Big breath. In a ladder pattern. Okay. We're also going to auscultate for bronchophony, egophony, and whisper pictriloquy at the same time. So if you could say 99 again.
99, 99, 99, 99.
And E.
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 Thank you. We are going to go ahead and turn you back around, and we're going to talk through a breast exam for both male and female patients. With the inspection, we are going to inspect our female patients in 4 positions with hands at the side, hands on our hips, hands above our head, and also leaning forward in order to inspect for symmetry, contour of the breasts, as well as changes in skin or dimpling that may indicate an underlying mass. We are going to inspect our males visually as well, noting any color changes, any erythema, any discharge that may note an inflammatory infectious process. For the palpation of the breast exam, we're going to palpate from clavicle to the bra line, posterior axilla to the sternum in a vertical strip pattern, up and down, palpating for masses and noting the size, location, mobility, and any heat or skin changes associated with any processes that you are finding. You want to make sure that you also are inspecting the areola and nipple for elasticity, as well as any discharge that you may have, again indicating an infectious process. We're going to move to the posterior or the anterior chest wall. So we're going to sit him straight up, and we're going to visualize. We're going to look for any retractions, any use of any accessory muscles that may indicate any respiratory distress. We're going to palpate again for tactile fremitus, as well as any thrills or heaves. We're also going to palpate while we're here for point of maximum impulse. Lean forward just a tiny bit, which should be at the 5th intercostal space, mid-clavicular line, most distal point of tapping in the apex of that heart. Okay, go ahead, sit straight back up again. We're going to percuss again for resonance. Ensuring that we don't have any hyperresonance or dullness that would indicate a disease process. We're going to auscultate again in a ladder pattern, listening for any adventitious lung sounds, ensuring that we don't have any wheezing that would indicate a narrow of the bronchioles, and including those lateral lung sounds as well. While we're here, we're going to go ahead and we're going to lean him forward a little bit to move the heart for hand sanitizer. Move the heart forward in the chest cavity so that way we can auscultate. We are auscultating at the 2nd intercostal space for aortic sounds, the 2nd intercostal space on the left for pulmonic sounds, 3rd intercostal space is Erb's point, 4th intercostal space is tricuspid, and 5th intercostal space at mid-clavicular for mitral sounds. We're going to auscultate with the diaphragm for S1, S2. And again with our bell for any murmurs or whooshing that is out of place, indicating any valvular issues or other underlying disease processes. We are going to have you lay down. We're going to measure for jugular venous pulsation. So with the head of the bed at 30 degrees, turn your head to the side just a little for me. Thank you. We're going to find the meniscus of jugular venous pulsation, just the uppermost area of pulsation. And we're going to use a centimeter ruler at the sternal notch and take a piece of paper. In this case is my Snellen eye chart. And we are measuring from that point of maximum pulsation across to our ruler, which in this case is 2.5 centimeters. We should be less than 3 centimeters within tolerances. While we're here, we're going to move to the abdomen, making sure that we're still appropriately draped. We're going to expose the abdomen and we're going to visualize, looking for any obvious peristalsis. We're looking for any striae, we're looking for any masses, any pulsations. And before we get in there and move anything around, we're going to have a listen and auscultate our bowel sounds. We are going to also auscultate at the aorta and the femoral arteries for any bruit or any whooshing that may be out of place. At this point, we're going to go around with light palpation, all quadrants, ensuring that we're not eliciting any pain or tenderness. We're going to move to deep palpation. So if you don't mind, take a breath in, let it out. All of our quadrants. We're also going to ensure that we are palpating back. Okay. Deep breath, let it out. Palpating for kidneys and spleen. Palpating on the other side. Kidney, liver. We are going to percuss as well. Looking for tympani, any areas of dullness that may be associated with underlying organs. Percussing over the area of the spleen. We're also going to percuss our liver margins at this time, so at the umbilicus. Looking for the dullness. And we're going to go from midclavicular line down. Okay, and we're going to measure that again with our centimeter ruler, which in this instance is 9 centimeters and within appropriate tolerances. Following our abdominal assessment, we are going to assess our lower extremities. If you don't mind straightening your legs out for me. We are looking at our extremities for any color changes, hair disbursement pattern, any changes to the texture of the skin. We are going to go ahead and dorsiflex our feet and check for pain in the back. Up. Thank you. Dorsiflex and up. No pain in your lower back.
Ma'am.
Perfect. We are going to test for range of motion in our hips. So we are going to flex, keep your knees straight, and extend, abduct, adduct, external rotation, internal rotation, and the same thing, flex, extend, adduct, external rotation, internal rotation. We're going to do the same thing with the knees, flex, extend, internal rotation, external rotation, flex, extend, internal rotation, external rotation. With our ankles, we're going to move down and we are going to ask for our patient to flex down, plantar flexion, dorsiflexion. We're going to test strength at the same time. So go ahead and pull up, push down towards me. Perfect. We're also taking a moment to look at our toes, check for our capillary refill, look at the texture, color of our nails. While we're here, we can check for proprioception as well. So closing your eyes, tell me which direction I go.
Down. Up.
Thank you. We're going to go ahead and work on our peripheral vascular assessment. So again, we've already looked at color, we've looked at temperature of the skin, we've looked at hair disbursement, indicative of any cardiovascular processes. We're going to look for popliteal artery. Thank you. Dorsalis pedis. And posterior tibialis. Thank you. We're going to come up here. Nope, arms up. And we're going to test for brachial and radial pulses, all of which are +2 as expected. We'll have you sit up and take your legs off the side of the exam table.
Thank you.
Yep. We're going to test range of motion in your shoulders. So arms out, arms across, adduction. We're going to put our hands behind our head, testing external rotation, and hands behind your back, testing internal rotation. Thank you. Arms back in front. We're going to test straight out with your shoulders, or with your elbows, your little shoulders. You're going to pull up towards me, all your strength at the same time. Pull up. Oh, not so much strength. Push me away. Thank you. I appreciate you. We're going to look at our wrists as well. Wrists. We're going to test our pronation and supination. And over. And now quickly, checking also our cerebellar function at the same time. Fingers and knuckles. Again, we're going to take our time, look at our capillary refill, check our texture of our nails, look for any clubbing of our fingers. We are going to test point to point. So if you don't mind, close your eyes and touch the nose with the finger that I point to. Okay, thank you so much. If you'll turn your hands over, close your eyes again. If you could tell me, we're testing narrow sensory, so tell me what number I write on your hand.
7.
Okay, and this one.
An 8.
Okay, and if you could tell me what I place in your hand with your eyes closed.
Feels like a coin.
And the same over here.
About the same, about a coin.
Okay, if you don't mind, we'll do point to point with your heel to your shin as well. Heel to shin, heel to shin. Perfect. Let's see, where are we at? Okay, go ahead and stand. We are not. We're going to have a seat. We're testing reflexes. So tricep reflexes. We're testing bicep reflexes. Brachioradialis. We're watching for, okay, hang your legs. Hang, hang. Patellar reflexes.
Oh, fun.
Checking for any hyperreflexia. Checking at the Achilles. Okay, go ahead and stand for me. We're going to do a Romberg test, further testing our neurological function. So eyes closed, making sure that our patient can maintain balance with their eyes closed without any swaying. Very good. We're going to have you turn this way and we're going to have you bend over as far as you can towards your toes. We're looking along the spine for any pain with palpation, any abnormalities, any deformities, any pain. We're also looking for any abnormal curvatures. We can palpate at the sacroiliac joints as well at the same time. And if you can come halfway up, thank you so much. The same thing, just ensuring that we don't have any abnormal curvatures of the spine that would indicate any scoliosis, lordosis, kyphosis, or anything of the nature. Okay, go ahead and stand up. We'll finish our neuro exam with testing gait. So if you don't mind walking forward, heel to toe, heel to toe. Okay, and then turn around and come back on your tiptoes. And then on your heels. Perfect. If you don't mind having a seat, we're going to talk through our genital exams and rectal exams for both our males and our females. For our male patients, we would perform a rectal exam in the left lateral recumbent position. First, a visualization of the perineum and perianal area, ensuring that we don't have any masses, any induration, any erythema, or anything like that that can indicate any disease processes. We're going to perform a digital exam by inserting a well-lubricated finger into the anal vault and rotating in counterclockwise fashion, noting any nodules, any irregularities that we may have. We're going to take care to palpate the lateral lobes of the prostate, as well as locate the median sulcus, and note the size, shape, symmetry, and mobility of the prostate. For the remainder of the male genitalia, we are going to visualize both the penis and the scrotum. We're going to visualize the glands, the foreskin, the shaft of the penis, as well as the scrotum for symmetry, any irregular bulges, or anything of that nature that may indicate a hernia. We're looking for any varices in the scrotum that may indicate any vasculature issue, and we're going to palpate the scrotum, palpating each testis individually, along with the epididymis and spermatic cords, for size, for presence, for shape, and any abnormalities. We're also ensuring that we don't have any ulcerations or abnormalities of the scrotum, the penis, or any of the surrounding areas for the male. For our female, we're going to ensure that she has had an opportunity to void her bladder. We're going to lay her down and appropriately drape her from the middle of the abdomen to the knees. We're going to assist her into the lithotomy position, and we're going to visually inspect the external genitalia, starting with the mons pubis and the labia and perineal area for any abnormalities, any induration, any redness, any ulcerations or abnormal growths that may need to be evaluated. We are going to perform an internal exam after obtaining consent, in which we choose the appropriate size speculum for our patient, insert that well-lubricated speculum into the vaginal wall at applying downward pressure, and opening the speculum using the thumb screw after reaching the cervix. We're going to open the speculum, visualize the cervix and the cervical os, and inspect for any induration, for any ulcerations, any abnormal growths, any discharge from the cervix. To perform a pap smear, would be using a cervical broom that we inserted to the middle of the cervical os and made a complete 360-degree sweep of the cervix before placing that into our specimen collection container, and then slowly and carefully withdrawing the speculum to visually inspect the vaginal wall on our way out for those same topical anomalies. we are going to perform a rectal exam as well as a bimanual exam on our female patients, in which we are able to palpate ovaries and uterus and any higher location of rectal masses or anomalies via that bimanual exam. Thank you for your time.